Okay, good evening, everyone. So it's my great pleasure to welcome you all at one of the Saudi Society of Blood Disorders events. My name is Firas Al Frayeh. I'm one of the hematologists at King Faisal Specialist Hospital. So today is one of the series of MENA Forum for Challenges in Hematology, which is a monthly event organized by Saudi Society for Blood Disorder. Each month we go over a different topic. I would like to thank the sponsors for this event. Platinum sponsor is Janssen and Hikma, the gold sponsor. Today we are having a renowned speakers who will share with us their experience. Professor Nitin Jain from US, Dr. Ahmed Al-Hareji from the Kuwait, and Dr. Nasser Bakhri from Saudi Arabia, King Faisal. The program will be, Dr. Nitin Jain will give a talk for 25 minutes about Philadelphia-like acute lymphoblastic leukemia. Then we will move to the clinical challenges presented by Dr. Hareji, followed by diagnostic challenges presented by Dr. Bakhri. Please write the questions in the Q&A tab. In the last 30 minutes, we will go over the questions. I would like to remind you that that the webinar is recorded and it will be available in SSPD channels. CME will be granted automatically for those who joined the meeting and attended 50% of the event. Without any further delay, it is my great pleasure to introduce Dr. Nitin Jain. Dr. Nitin Jain is a professor at Department of Leukemia and MD Anderson. He's a renowned speaker in leukemia with many publications. Dr. Jain, the floor is yours. Dr. Jain, you are mute.
Hello, can you hear me now?
Yes, I do hear you now, and I'm able to see your screen. Just kindly maybe, yes, now it's presentation mode.
Okay, perfect. Hello, everyone. Good evening to you guys. Sorry about the technical issue. So my specific topic today is to talk to you today about pH-like ALL. So in the next maybe 25 minutes or so, I'm going to review this topic. So we know that outcomes of pediatric ALL, this is a series from pediatric COG group, sequential COG trials. And as you can see that, the outcome of kids with ALL has remarkably improved. And now we are talking about 10-year survival of upwards of 90%. However, when we look at adult patients with ALL, and this is an old data set, but an important thing to emphasize is that things have not changed that dramatically. Maybe they have improved by 10 percentage points, but still we're talking about a 5-year overall survival of maybe around 50% for adults with ALL, as compared to kids where we are talking about 90+ survival. So there are a lot of factors obviously come into play between the adults and the peds population. But one of the factors we have investigated is this entity called pH-like ALL. So what is pH-like ALL? So before we go into that, obviously you're aware of major subgroups of ALL. These are very big picture subgroups: pH positive, obviously Burkitt's, MLL, and then we have this somewhat new entity of pH-like ALL. So what is pH-like ALL? So pH-like ALL, this concept arose back in 2009. So now, over a decade ago, where investigators, one from Dutch group and one from St. Jude's group in USA, they were looking at gene expression profile of patients, initially were children with actually ALL, and they found that there were a group of kids whose gene expression profile was similar to pH positive ALL, but they didn't have the Philadelphia chromosome or the BCR-ABL1 transcript. So these patients were then labeled as BCR-ABL-like ALL for the WHO classification, or we also call them as PH-like ALL. And I will kind of explain to you a bit more what the gene expression profile is and what that really means. So these were the two papers which came back in 2009. And we'll review a bit the first paper, which was from the Dutch group, looking at the pediatric patients with ALL. So what the investigators did was, this is just a kind of a gene panel. They tried to segregate patients into different gene subgroups. And as you can see, and just maybe the bottom half where I have written PH-like ALL. So there was this group of patients, as you can see, some patients were TALL, they're segregated differently, MLL segregated differently. But then there's a group of patients which segregated together with BCR-ABL. But these patients did not have the Philadelphia chromosome. So the investigator just called them as BCR-ABL-like or later PH-like. So this was based on a gene set of 110 genes, and based on the differential expression of those genes, you were able to segregate patients like this. And then this was validated in other subgroups as well, in terms of the PH-like signature. So one thing to remember about this entity is that these patients do not have the recurrent genetic abnormalities. For example, if someone has MLL rearrangement, that's not PH-like ALL. If someone has known translocation, 1221, 119, that is not PH-like ALL. But why do we matter? Why it's important for this to matter? And this was because of this survival curve, early first one, where when the group from Holland, the same Lancet Oncology paper, when they looked at the outcome of these patients, the PH-like ALL, and these are children, so the outcome in general is good if you look at the top green line. But then if you look at the red line, which is kind of dropping down, that's PH-like. And then the black line is pH positive. So certainly that created a lot of interest, that these are the group of patients which have something which is causing them to behave more aggressively, despite they're getting uniform chemotherapy, as all other BALLs. So what is that genetic abnormality? So that the first paper in this regard came from Charles Mulligan's group in St. Jude's, work by Catherine Roberts, where they looked at a bunch of patients, actually. So this was almost 2,000 patients with BALL, including some from MD Anderson, where overall, among these 2,000 BALL patients, 15% had PH-like ALL, based on, again, this gene expression profile. And then they did further sequencing of these patients. So what is the incidence? So the incidence here is highlighted in the red kind of a pie chart, where in kids, it's around 12%, in adolescents, it's around 20%. And when you look at young adults, so age 21 to 39, it's almost 27% in this large series. So it's not a small percentage of patients we're talking about. This is a substantial number of patients in each age group who have PH-like ALL. And when they look at a lot of abnormalities on these patients, this is just from the supplement of this paper, where I just want to highlight that PH-like ALL is not just one entity. It is not like pH-positive ALL, where you have one genomic abnormality, obviously BCR-ABL, and that's pretty much defines it. If you look at PH-like ALL, they are like many abnormalities which could occur, some of which are kind of listed here. They could be mutations, they could be fusions. So it's a bit of a diagnostic challenge how to figure that out, and I'm going to explain at least how we are doing at MD Anderson. So how I kind of look at it on a big picture view from a clinician standpoint is that if you look at PH-like ALL, it comes in two different kind of subsets. Half of the patients will have an overexpression of a gene called CRLF2, and and half of those patients will have JAK2 mutations, typically JAK2 R683. The remaining half of the patients can have a variety of different fusions to different genes, mutations of different genes. And that's where you really have to do some kind of a multiplex fusion assay to pick those patients up. But at least the half of the patients who are CRLF2 rearranged, they are a bit easier to figure it out. And I'm going to explain in the next few slides, at least how we do it at MD Anderson. So an important aspect is what is CRLF2? Because if you're thinking about PH-like ALL, this is a terminology you will see quite often. So CRLF2 is actually a cytokine receptor gene, which is located on chromosome X or chromosome Y for men. So in actual patients who have this rearrangement, there is actually a translocation which can happen from chromosome 14, IGH locus, to CRLF2, or there could be a small deletion within chromosome X leading to this P2RY8 CRLF2 fusion. So there are two different genetic abnormality fusions which are occurring in these patients, and both these lead to overexpression of CRLF2 on the surface, which can be detected by flow cytometry. That's what we do at MD Anderson, or you can do a FISH for CRLF2, and you can figure it out if it is rearranged. But then if you're looking at the non-CRLF2 cases, they are, again, as I mentioned before, you could have a variety of different fusions, variety of different rearrangements. So it's not one single abnormality which defines that. Now, it's also important to maybe highlight is that the JAK2 mutations which occur in PH-like ALL is different than what we know in MPNs. So as far as I know, no patient yet have been described with V617F mutation within PH-like ALL. So these are the patients who will have different mutations, as is kind of shown in this figure here. And the most common one is R683G. So if you're looking for a JAK2 mutation in a PH-like ALL, you have to have a panel which spans all the exons. If you just look for V617F mutation, that won't pick it up. So we did some work in this regard, and I'm going to share you some data from MD Anderson studies, which we published now a few years ago. What we did is we collaborated with the St. Jude's group with Charles Mulligan and Catherine Roberts. We sent them the samples from MD Anderson. And just a nutshell, in 148 newly diagnosed patients at MD Anderson, you can see here, not half, 1/3 of the patients were PH-like ALL. So quite a bit of patients were PH-like ALL. 1/3 approximately were PH positive, and 1/3 were all others. And 60% of these patients were CRLF2, and the remaining were non-CRLF2. So again, PH-like ALL constitutes actually a substantial number of patients we see at MD Anderson. When you look at these patients in terms of their different age and other groups, there are some things which are kind of significant, but overall nothing major remarkable. But the important thing is their ability to achieve remission. So if you give them induction chemotherapy, what it looks like is that at least the patients are going to achieve a CR. But if you're looking at the MRD negative CR, which obviously we want for patients with BALL, for PH-like ALL, it was only 30% were MRD negative after induction, as opposed to 87% for patients who did not have PH-like ALL. So really, a substantial difference in terms of able to achieve MRD negativity. And that then correlates with outcomes. So this is patients segregating PH-like versus B others. All these patients receive frontline induction therapy at MD Anderson. And as you can see, the curves are nicely kind of separating out. In this study, some patients got pediatric regimen, some patients got hyper-CVAD regimen. So if we just look at hyper-CVAD to compare equally between the two genomic subgroups, as you can see, the curves are again very nicely separating. PH-like ALL doing worse compared to hyper-CVAD. And then when we look at the two subsets, I mentioned to you there are two subsets. One is CRLF2, one is non-CRLF2. And really it appears that most of the worst players are CRLF2 patients. So this is the blue line here, which you can see the curve going down. And even among the CRLF2 patients, if you happen to have the JAK2 mutation, and half of these patients typically have JAK2 mutations, that even worse. So basically, CRLF2 is the bad player, and if you happen to have concomitant JAK2, that's even worse. Now, one of the interesting thing which was initially noted by the St. Jude's groups, and we also confirmed it in the adult group, is that majority of the patients with PH-like ALL are actually of Hispanic ethnicity. So in our series, as you can see, among the 70 patients who were Hispanic in the overall cohort, 38 of the 70 patients were PH-like ALL, as opposed to 13 out of 60 Caucasians. So there is a preponderance of Hispanic patients, and that's thought to be because of some inherited polymorphism of a gene called GATA3, which we also recently published on. So there is some genetic predisposition for Hispanic patients to have this polymorphism leading to PH-like ALL. And when we put this PH-like ALL in a multivariate analysis for survival in this series, as you can see, the factors which came out: age, white count, platelet count, and PH-like ALL. So kind of what we kind of maybe expect for these patients. Now, one thing some of you in the audience may be wondering about how, okay, that's great, but how do we diagnose these entity? So at least I can tell you how at least we are doing at MD Anderson. So for the last maybe 4 or 5 years now, CRF2 is part of the standard flow cytometry panel, which is a standard ALL flow panel. So it's easy because any newly diagnosed patients or relapsed patient who comes through the door, the flow panel has the CRF2, and we have shown that there is really 100% concordance of flow. If you're positive by flow, and if you do a FISH, it's going to be positive as well. So really, flow is a very easy way to detect these patients, and at least you're able to cover half of these patients. If you have a molecular assay covering JAK2 mutation, that also helps, but again, it's not a 100% requirement. As I said, half of the CRF2 patients will have a JAK2 mutation. We also, in our cytogenetics lab, have a FISH panel covering different genes, which are listed here, which are the other rare fusions which have been noted in patients with PH-like ALL. And if you have, this FISH panel that can detect those. But I think what we are doing now in collaboration with the COG lab, and now it's going to be an in-house panel as well, is this panel called Archer Fusion Panel, which is a commercially available panel, which is now also used by COG. And we are going to have it in-house, which can detect all these fusions for PH-like ALL, in an in-house panel. So then we don't have to do a variety of these things. At least all the fusions, including CRF2, can be picked up by that panel. And just this is a slide I made some years ago, but I think I just want to highlight a point here that when we talk about these fusions, different genes could be rearranged with different partners. For example, ABL1, in the case of PH-like ALL, has been detected to be fused to so many different genes which are listed on the slide here. Obviously, ABL1 is Philadelphia chromosome, but you can see a variety of different genes for ABL1, JAK2, and others. So again, all these fusions can be now assessed by this multiplex fusion panel. So in the last maybe 10 minutes or so, just, okay, what about the treatment? So I told you how we are kind of, what is the relevance, prognostication, importance, how at least we are detecting these patients at MD Anderson. But what about the therapy for these patients? So some years ago, 8 to 10 years ago, as this entity became known, and there was some very nice work by Charles Mulligan's group that ruxolitinib may work for JAK2 fusion patients or CRF2 patients, and dasatinib may work for ABL fusions. And then there were a lot of case reports which started coming in the literature. Some of them are listed in the slide here. So we got interested, and we actually, I believe, one of the first studies looking at this concept. So we designed a study which was for PH-like ALL, relapsed refractory adult ALL, age more than 10 years. And we do this testing, which I just mentioned to you about. And based on the profile of these patients, they were randomized, or not randomized, they were given either ruxolitinib plus chemotherapy, if we think that they have an abnormality which leads to JAK-STAT activation, or if they have something which leads to ABL1, ABL2, PDGFR beta fusion, which you would think would respond to dasatinib. So we started this trial back in 2016 or so. Now, we reported these results a few years ago, actually, and in summary, I can tell you that we have not seen really much activity with ruxolitinib for these patient population. And now in the slide here, you see 8 patients with ruxolitinib. Now we have treated 11 patients since that time, but we haven't really seen much responses, just one patient with a transient response. So we have not been very excited about this activity of ruxolitinib for PH-like ALL based on our data. So actually just recently we have decided to close this trial because of the lack of clinical activity. Having said that, this strategy is being explored in children. And this is a study, a slide from a couple of years ago now, reported by Sarah Tasian, where in kids, what they're doing is that as part of this children's oncology group study, if the child has a pH-like abnormality, and after induction they are still MRD positive, then they continue with their next consolidations, but ruxolitinib is added. And the dose of ruxolitinib is a bit different. You see here 50 milligram per meter square twice a day, 14 days off and 14 days on and 14 days off. So slightly different. They're not using continuous ruxo as we are used to in MPNs, or at least what we do in our study. They're using this 2 weeks on, 2 weeks off schedule. And what they showed at that time is that some of these patients actually achieved MRD negativity after the ruxolitinib was added. So, so I think that was 2 years ago. I'm looking to see an update of this data because I'm sure they have many more patients treated at that time and a longer follow-up to really see whether this is a valid strategy or not. But at least, as I said, in adults in relapsed refractory setting, we did not really see much activity. Now, in the last few minutes, so ruxo I talked to you about. But what about other drugs we know, which are, inotuzumab, plenatomab? These are the two phase 3 studies, which was reported by Dr. Kantarjian from our group in New England Journal a few years ago. Obviously, you're well familiar with these data with inotuzumab and plenatomab. So one of the questions in the field is, what all the data I showed you up until now was practically chemotherapy. Chemotherapy and then the outcomes of PH-like ALL. But an important thing which is still kind of missing is what happens with newer therapies for PH-like ALL. So obviously inotuzumab, plenatomab, and this is CAR T, right? I mean, CAR T is a big thing now, at least for pediatric ALL, adult diffuse large B-cell lymphoma. And now we are seeing data occurring in adult ALL as well as CLL. And this just a representative slide provided to me by Satwan Nilapu in our group, where you can see that a lot of these CAR Ts are obviously FDA approved in the US, and some are in the process of being approved. So another question remains, can you negate what is the response of PH-like ALL, CRL2 re-enriched patients with CAR T? And I think that's something which is not yet really known. Now, there is some new data. Actually, this paper just came out in Blood in the print version last week. This is a collaborative effort from City of Hope and St. Jude's group, where adult patients treated with plenatomab, they looked at their genomics and then how many patients responded. And overall, they had 42 patients in which 23 of the 42 patients responded to Blena. But then when they did the PH-like profile for these patients, and as you can see on the figure, and the actual numbers are listed on the slide as well, quite remarkably, 12 out of 16 CRF2 patients responded, had a response with plenatomab. This is single-agent plenatomab. And again, reasonable number of patients with non-CRF2 PH-like also responded, but the numbers are kind of small. So an argument is made that plenatomab may be able to overcome the negative prognostication of PH-like ALL. Now, having said that, I think that these are 16 patients. As far as I know, they did not provide progression-free survival of these patients. So we'll have to see, and this has to be validated in other data sets. And I think a similar data also needs to be assessed for inotuzumab, because again, both inotuzumab and plenatomab work through they're not chemotherapy. So I think if sort of two patients have JAK-STAT activation, hopefully both Plena and Inotuzumab, and for that matter, maybe CAR-T, can overcome that negative prognostication. But as I said, this is one of the first data sets kind of reporting that SIRF2 patients can do well with Plenatomab. So coming to my kind of last slide and maybe a brief summary slide at the same time. So our practice at MD Anderson for these patients, if you are newly diagnosed patients, at this time, our frontline trials at MD Anderson, we are not relying only on chemotherapy. As many of you may know, we are incorporating Inotuzumab as well as Plenatomab in the frontline regimen, like in sequential cycles. So I think that's really important for these patients because, as I showed you, chemotherapy alone is not the answer. And at least in my practice, if someone becomes MRD negative, I try to transplant them in CR1, especially obviously if they're young and of transplantable age. In the relapsed refractory setting, I think, as I mentioned, we tried the ruxolitinib study. We haven't really seen much activity, so we have closed that kind of chapter to say for now. And I think we're trying to see if, and again, this is the data which needs to be generated. Some data with Plenatomab, but we need data with Inotuzumab and CAR-T. And again, certainly for any relapsed refractory ALL, doesn't really matter if PH-like or not. If you're able to get to MRD negative and the patient has a donor, I think certainly transplant should be a strong consideration. So thank you for your time. I think I'm right on time as well. So happy to take any questions in the panel discussion or right now, depending on the schedule. Thank you.
Thank you, Prof. Jain. Excellent talk, as usual. We'll leave the question at the end. Now we will move to the next speaker. So Dr. Ahmed Al-Hareji is a hematology consultant from Kuwait Cancer Control Center. Dr. Hareji will try to talk about some clinical challenges. Dr. Hareji.
Assalamu alaikum. Good evening, everyone, and thank you, Firas, for your kind invitation. I'm very happy and glad to be here with our colleagues and friends from MD Anderson, as well as from King Faisal, Dr. Nitin Jain, whom I work with, and Dr. Nasser Bakhshi as well. Today, I'll be speaking about some challenging cases that we face at Kuwait Cancer Center, and I'll take you initially with a brief overview about the Kuwait. So Kuwait, as you know, is so Kuwait, 30% of our population is Kuwaitis, and around 70% are non-Kuwaitis. And out of that, 2/3 of them are male and 1/3 are female. And Kuwait has like 4.6 million population, and the majority of those patients are below the age of 55. So we tend to have a younger population. ALL cases at Kuwait Cancer Center from 2014 until 2019, we excluding patients below the age of 16. So we accept patients above the age of 16. We tend to see like around 20 to 25 patients per year of acute lymphoblastic leukemia with a male predominance of 3:1. And usually the Kuwaitis is around almost 40% of those. Our first case is Mrs. F.A., who's a 75-year-old lady back in 2014 with the comorbidities of diabetes and dyslipidemia. She presented with anemic symptoms, and she had a normal renal cardiac function with a good performance status. Her WBC showed a WBC of 5.7 and hemoglobin of 75, platelet of 65. Her blast was 30% in the peripheral blood. The bone marrow at that time showed a hypercellular marrow with 75% blast, and the cytogenetic revealed a diploid karyotype with negative PCR-APL on FISH. Her flow cytometry was consistent with acute lymphoblastic leukemia P cell, CD10, 19, 22, 79, and TDT and HLA-DR. And as we know, those patients, based on the SEER data, they are diagnosed with ALL at the age of 75. They usually tend to have median survival between 8 to 9 months. So really a difficult population to treat. So at that time, we So we'll take a first question. How would you treat this patient? Would you treat her with intensive therapy with hyper-CVAD plus rituximab, mini-CVD with rituximab, or steroid vincristine, or you would refer her to palliative care, given the outlook of this disease at the age of 75? So I wonder if there is any poll question for us.
We have not prepared it in advance. If you haven't notified us, we will build it.
Okay.
Probably
Anyway,
you have to move forward. Sorry about that.
I'll move forward. So at that time, we treated her with mini CVD for 2 cycles, and her blast was high, 20% after 2 cycles. So what would you do at this time point? Would you send her now for palliative care, or you would enroll her in clinical trials if possible? So the patient was enrolled in mini CVD plus inotuzumab at MD Anderson. She was able to travel there. She completed in 2015 4 cycles of mini CVD plus inotuzumab. She achieved MRD negative remission, and she finished her pump maintenance back in December 2016. And she was kept under regular follow-up in our OPD. In February 2020, the patient presented with generalized pain, and her ECOG was still good of 1. She had no lymph nodes or hepatosplenomegaly. Her CBC showed that she has a leukopenia of 2.2, and hemoglobin of 11.6, platelet of 70, and neutrophil of 0.6. She had a normal renal, cardiac, and hepatic function. Her bone marrow was hypercellular with 35% blast, and this time the flow cytometry was CD20-22 negative. So she, remember, she was treated with inotuzumab, and now she's CD22 negative. And but the CD10, 19, and 79 were positive. So probably she is relapsing with a CD22 escape mechanism because she had received inotuzumab in the past. Her cytogenetic remained diploid in 10 metaphases, and the BCR-APL was negative by PCR. So it is really difficult because at this time, it was in February 2020, and we were in the start of the COVID-19 pandemic. And given her age and a relapsed disease of PALL, the situation was really difficult to how to treat her. She wants to get the best option for treatment. So we discussed her extensively, and these are the options. And then for the sake of time, I will continue. So we treated her with mini CVD plus Plenatomab off-label, and post-cycle 1, she achieved MRD negative remission, and she tolerated the first cycle very well. Initially, she developed some infusion cytokine release syndrome that was mild and was treated with the discontinuation of Plenatomab for 1 day and steroids. So in April 2020, she completed 3 cycles of mini CVD, and she was in 2nd cycle of Plenatomab. Post 3rd cycle of chemo, she had a delayed count recovery of neutrophil and platelet with a grade 4 neutropenia. And that time she developed E. coli bacteremia. And we were at the peak of the COVID-19 pandemic in Kuwait. And this is the schema of mini CVD plus Plenatomab, where you give mini CVD, and at day 5 you start Plenatomab, and then every 4 weeks on and 2 weeks off. You give this for 4 cycles, and then you transition the patient for maintenance, and then you alternate the pump along with Plenatomab every 3 to 6 months. So we repeated her bone marrow because of the delayed count recovery, and we were afraid of the relapse at that time. The repeated bone marrow showed a hypocellular marrow with no evidence of leukemia, and the flow cytometry remained that she is MRD negative still. So we gave her GCSF, we gave her IVIG because she had hypogammaglobulinemia because of the Plenatomab, and the Plenatomab was restarted at a lower dose of 9 mics per day. And this is the how would you treat the adverse events of Plenatomab if the patient developed a cytokine release syndrome of a grade 3? You withhold the Plena, and then you restart at a lower dose of 9 mics per day and escalate after 7 days if there is no toxicity. If the toxicity occurred, then you go back at 9 mics per day, then or the toxicity takes more than 7 days to resolve, we discontinue the Plenatomab permanently. If the patient developed seizure, the Plenatomab will be discontinued permanently. And if she developed grade 3 neurologic toxicity, again, you withhold the Plenatomab for 3 days and then restart Plena at 9 mics per day. And an earlier administration is permitted if felt to be in the best interest of the patient and after discussion with the principal investigator. And this is, I think, in the mini-CVD hyper-CVAD protocol. And to escalate to 28 mics per day after 7 days if there is no toxicity occurred. But the other clinically relevant adverse reactions, like our patients who had a grade 4 neutropenia, we withheld the Plenatomab for 1 week, and then we restarted because of we thought that the chemotherapy might play a major role here. And then we restarted the Plenatomab at 9 mics per day. And the toxicity of neutropenia and thrombocytopenia did not recur anymore. So again, the Plena was resumed at 9 mics per day, and she completed the 3 cycles of mini-CVD. And we said she has probably at the age of 80, no bone marrow reserve since she received the previous chemotherapy, and now she's receiving another chemotherapy. So we elected that she got the maximum of chemotherapy at this stage. And we completed 4 cycles of Plenatomab, 4 weeks on and 2 weeks off. And then transitioned to pump maintenance. She had 3 cycles of Increstin, and then she was readmitted for Plenatomab at 9 mics per day for 1 month, and then back now to pump maintenance. So I would like to hear the comment of Dr. Jain on this case, please.
Yeah, so I think you managed it amazingly. I think this is kind of a patient which I think amplifies that, all these new therapies, we have Incidence, Plenatomab, how these therapies have improved the outcome of this patient. I mean, if these were not available or not accessible to the patient, she likely would not have made it past 2016, and then she was able to get remission, and now so I think the management has been perfect. And I think obviously we don't see these positive responses in all the patients we treat with these drugs, but I think it's always good to see such a response. And I think, and this is what we try to do as well here for patients to cycle them through these novel therapies, sometimes in combination, sometimes a single agent, to try to prolong their survival. And she's obviously, not a transplantable age, but if someone was young, you would have obviously considered transplant, back in 2016 for her.
I see. Thank you. So our next case is a 59-year-old Kuwaiti male patient who was diagnosed with B acute lymphoblastic leukemia in May 2020. His WBC in presentation was 1.3. He had a CNS negative disease and CD20 positive. He was pH negative, and he was hyperdiploidy on the cytogenetics. He was treated with, at our center, we treat these patients above the age of 25 to 60 with our hyper-CVAD. So he received 3 cycles of hyper-CVAD. Post cycle 1, he achieved MRD negative remission. During cycle 3, he developed COVID pneumonia that was in July 10th, 2020, and he recovered clinically out of the pneumonia, but he had a persistently positive COVID swab that lasted for 2 months after the cycle 3. And we were in a debate of whether to take this as a positive, the positive swab, to take it as a really pathogenic and maybe puts the patient at a higher risk of infection and then mortality, or just disregard since he recovered clinically and his chest X-rays is okay, and then resume his chemotherapy because he has ALL that if he relapsed then, or he had a relapse of his disease, then the outcome would be extremely poor. We did his SARS-CoV-2 IgG and IgM, both were negative. So we were in a debate whether to restart or not to restart. We discussed and counseled the patient extensively, and we discussed him in our MDT. And the final decision is to take the patient for cycle 4, even with a positive COVID swab. But at this time, he was admitted, and we gave him hyper-CVAD, but without rituximab in cycle 4. And the IgG profile was tested and was low, and we tried to maintain his IgG level above 6. His course with cycle 4 was uneventful, and he recovered his count on day 16 with a negative repeated swab on discharge. And the patient completed 8 cycles now, and he is transitioned to pump maintenance. In this case, I would like to ask Dr. Jain and to maybe Dr. Faras as well, on how to manage in your center the patients with ALL in case they developed COVID pneumonia in the middle of the cycles.
Yeah, so I think our management is very similar. I think patients who are actively infected, I mean, this is just like the diagnosis of COVID pneumonia. We obviously hold the therapy during that time frame, try to get them better, whatever a few weeks it takes. And you know, then try to resume their therapy back. Now, in our center, you know, this issue, and I'm still no expert in this COVID-19 infection, but I think, you know, our center, they ask us not to retest these patients later on, like a month down the line or 2 months down the line, because of this, maybe the long-term shedding of the virus, which is maybe not infectious. So I think once a patient is clinically well, you know, we are resuming the therapy as you kind of did in your patient as well. So our management is kind of similar. Obviously, if someone is actively active COVID pneumonia, as I said, we try to hold their chemotherapy or whatever they were receiving at that time, and give them Neupogen or IVIG and things like that, at least to maintain their immune suppression.
From my side, Ahmed, I mean, our practice is similar. I mean, if it is COVID stage B or C, definitely, or D, definitely we hold the treatment. If it's asymptomatic COVID, then probably we might proceed. We had a patient who had a COVID pneumonia, and similar to what Dr. Jain mentioned, that when can we restart? His COVID test continued to be positive, and that was at the beginning of the pandemic. ID actually recommended to proceed with treatment after 3 weeks. So we did that, and gladly that the patient tolerated the chemo. He achieved remission. It was Plenatomab, and now he is post-transplant. Thank you.
Thank you all. So our next patient is Mr. Echai, a 56-year-old Kuwaiti male who had comorbidities of diabetes, hypertension, bronchial asthma, and ischemic heart disease post-stenting in February 2019. In July 2015, he was noted to have leukocytosis and thrombocytosis, and on routine investigations, his bone marrow aspirate and biopsy showed that he has a chronic myeloid leukemia in chronic phase. His cytogenetic revealed the Philadelphia chromosome with no additional clonal evolution, and his PCR was P210. He was started on the dasatinib 100 milligram, and at 3 months he achieved complete hematological response with a qPCR of 2.3, and at 6 months he achieved CCYR and MMR. At 2 years, he achieved a very deep molecular remission, and then he lost to follow-up since 2017. In December 2020, the patient, he was incompliant to his treatment, and he was feeling tired. He went to the hospital. He was vitally stable with good performance status. Now he has splenomegaly of 3 centimeters below the costal margin. The examination otherwise was unremarkable. His WBC now is 35 with a hemoglobin of 90 and platelet of 22 with a 48% circulating blast. We did his bone marrow that showed a CML in lymphoid blast crisis, and the blast was 70%. His flow cytometry consistent with PALL, CD10, 19, 22, TDT positive. We repeated his echo here and showed that his ejection fraction is 35 to 40%. Unfortunately, we did the APL1 kinase mutation that showed that the patient has a T315I mutation as well as E255K. So this is a CML lymphoid blast crisis, and we can usually those patients, they have a large discrepancy between the blast count and the pH clone, and they usually the pH clone is persistent when PLL in remission. BCR-APL fusion is detected in the segmented cell, and this will support the CML lymphoid blast crisis. And in comparison to patients with PH-BALL, patients with CML lymphoid blast crisis, usually they are older, they tend to have a higher leukocyte count and neutrophil, they tend to have a higher immature myeloid cells in peripheral blood, they tend to have a lower blast, and they usually have inferior outcome. And these are the mutations that we found in the patients. So T315I mutation only respond to Plenatomab, and the E255 is another bad mutation that has an intermediate or moderate resistance to Plenatomab. So the patient now is in lymphoid blast crisis with T315I mutation, and remember he is 61 with cardiac risk factor, including ischemic heart disease and low ejection fraction of 35%. So here we managed the patient we discussed his case extensively because this is a patient who in need for Plenatomab, and we know that Plenatomab carries a higher risk of cardiovascular complications, especially in those who are elderly and with cardiovascular risk factor. So we elected at the end that this patient is not fit for intensive chemotherapy, that's number one, and he's not fit for transplant. So we went ahead and give the patient mini CVD along with Plenatomab and Plenatomab. The Plenatomab was given at a dose of 30 milligram continuously because of the increased cardiovascular risk with 45 milligram dose. And this is a recent abstract presented at the last ASH meeting, looking at the outcome by the mutation status and the line of treatment on different dosing regimen of Plenatomab in patients with CML and chronic phase. If you look at the T315I mutation, the patients, they usually tend to respond nicely to 45 milligram, and then probably later on you reduce the dose as the patient respond later on. But if you start with 15 milligram, then those patients, they have almost a 6% efficacy and response rate. So we were in a tough call to what to do, to give 45 and by the risk of the cardiovascular complications, or to give it at a 30 milligram and then hope for the best. And this patient was given, as I said, mini CVD with Plenatomab along with Plenatomab at 30 milligram per day. He's currently finishing his cycle 1 that maybe written a few days ago, and he's probably will do his day 21 bone marrow in 2 or 3 days from now. And he tolerated the treatment very well. We managed we're doing a daily ECG on him. We're monitoring his cardiac enzymes and his electrolyte as well. So this is last case I have. And if you have any comment, Dr. Jane, on this.
No, and I agree completely with the management. I think, you don't want to use adriamycin, obviously, because of the cardiac issue. So I think mini CVD Plenatomab, and if you combine with Plenatomab, which I've done, I think that's wonderful. You could also say that Plenatomab by itself could also work for these patients, but we just don't know the data for CML lymphoblast crisis yet. So I think we would have managed very similarly what you did here if this patient was at MD Anderson.
Thank you. So with that, I will conclude and thank you for listening.
Thank you, Dr. Haraji, for excellent presentation, challenging cases. So we will move to the last talk with Dr. Nasser Bakhshi. Dr. Nasser Bakhshi is a senior hematopathologist at King Faisal Specialist Hospital. He's also the section head. Dr. Bakhshi, you unmute yourself.
Assalamu alaikum. Can you hear me?
Yes.
Now the presentation. I'm trying to do it again, but you have my presentation, right?
Yes. Okay. So
let's do one more time. I don't know what happened. It's just giving me a question mark when I try to share anything. Let's do last time. Bismillah. Okay. That's one more time. No, something I may have to redo everything again, but for now I will hold shift to slow multiple windows. Yeah, this
okay.
is you loaded it. Yeah, I think that's that. I haven't changed really much. So can I control it from here, Firas?
No, you won't be. So I will help you with the slide.
Okay, all right. Okay, so can you make it full window?
I have a PDF.
Okay, this is a PDF because I couldn't send you the full file. It was too big for PowerPoint to be sent on email file. So Bismillahirrahmanirrahim. Welcome to this last episode of the PACE presentation. I am a hematopathologist, as was mentioned, and I deal with mainly leukemias, lymphomas. So I have two interesting cases. One of them is has hopefully some useful message clinically as well. And the other one is really a sort of a rare entity, but also is a conundrum, both clinically and pathologically. So let's start with the first one. This is a 19-year-old male was referred to us. I mean, most of our material we get is referred, being the referral center in Saudi Arabia, and was diagnosed outside as T-cell lymphoblastic lymphoma, and we received the material from there, and we worked it up, and unfortunately, patient also started to showing circulating blasts in the peripheral blood. So a bone marrow was done. So before we do the next slide, Firas, please. We do the bone marrow. It's our routine practice to confirm the diagnosis from outside material. So we did that exactly. And no doubt there was blast population. This is the picture of the blast. And we worked up with some basic stains, and some of the stains were already done there. We repeated them. And it was clearly a B-cell lymphoma, sorry, T-cell lymphoma, and it was negative for CD20, as you can see in the stain. So next slide. So we confirmed the diagnosis. So while the patient came to the hospital, we did a bone marrow and we reviewed his peripheral smear, and which showed white cell count, which wasn't really high, but his platelets were down, and he had circulating blasts, and these were 42%. And some of the blasts, I have shown it here in the picture. I hope you can see it clearly. And they're not really big. They look lymphoid. They don't have much granules. The size is not that large, but some of them have these projections, which sometimes get called a hand mirror. But this is one of the morphological features of this entity, but it can be seen in other things too. So let's go to the next one. Bone marrow aspirate was pretty clear. 90% of cells were blasts. As you can see, hardly any hematopoietic cell. Next slide. So there was this population. I'm just highlighted the morphology of these blasts. Just apologize if this is a little out of focus. Yeah, go back, sorry. Yeah, so I'm just want to highlight that there are some blasts which have got indentation and in nuclear convolutions, which are quite typical for T-cell blasts. Next. And bone marrow was packed with the blast. Next one. And we went to do the flow. So this is important here because a lot of the information that we're going to, transmit today is based on flow information. So I'm just going to highlight some of the things. You guys see the cursor here, right? You're able to see. If not, then I will just apologize because I cannot really project this screen myself from here. So there's this blue population, which is the blast population, and then the red population, which is the lymphocyte population. So as you can see, right off the back, these blasts are negative for CD4 and CD3 and CD8. So this is the first thing that we realized, that these are negative for CD3 and CD4, as well as CD8. So that doesn't obviously rule out a T cell because, at the early stage, they can be negative for the surface CD3. Next. So these are B cell. This is a B cell tube. I'm not showing you all the markers. We have I don't know, 10 colors. So we usually do around 40 markers. So I'm just showing you the relevant ones here. Actually, DR was expressed, as you can see, in a partial manner, whereas all the B cell markers were negative. Next. And then we do the myeloid tube, and which we saw was a very clear expression of CD117, sorry, 117, which is, let's say, KIT, and it is a myeloid marker for sure. And so is CD13, and CD13 is not very bright, but it is there. And so is, I think here, I am showing you, I think actually DR, or I cannot see the whole thing here, but CD34 was also expressed. Next. So again, back to the T cell markers. So we are looking at something which is negative for CD8, CD4, and also do not express any surface CD3. CD56 was negative, 16 and 56, it was an NK. So only marker so far here I can tell you is CD7, and this is almost a similar brightness as the surrounding small reactive T cells. Next one. And other marker that was expressed was CD2. So it's CD2 and CD7 positive, negative for surface CD3, negative for 4 and 8. 1A was negative. So see, we have CD34. We have some myeloid markers and some lymphoid markers. So at this point, it raises a strong possibility of this being a biphenotypic leukemia. So next slide. Again, highlighting the same thing. I think there's a lot of a repetition here. Okay, we'll go to the next slide. Okay, so so this is our the panel for cytoplasmics and TDT. We did show TDT was expressed. Also it was a dim compared to our isotype control, which checks for any autofluorescence and background fluorescence, which it shows that it is more. So it is clearly showing some skew for expression for TDT. And a cytoplasmic CD3. This is your control, internal control, inbuilt control with the CD3 of the reactive T cells. And our population is, if not the same expression, but very close. So it is cytoplasmic CD3 positive expressing blasts. And MPO was negative, and 79A and CD22 also were negative. So from this, it's very clear we're not dealing with a biphenotypic leukemia. Well, we're dealing with a leukemia which is T cell essentially, but is showing many of the myeloid markers we discussed: CD117, CD13, and actually DR, and also has stem cell marker expression of CD34. And I didn't mention CD123 was also present. Next. So now this is a summary of the flow. This says the same thing what I said. So there was CD33, I missed that. Now we have this sort of picture. So I'm gonna, probably there's no question hour or, interactive portion here. But anyway, I think this raises a really strong possibility of what type of leukemia we're dealing with. If we go to the next slide, the answer is, it is which is described lately, like 10 years ago, or something called early precursor T cell acute lymphoblastic leukemia, ETP ALL, which is actually an important entity to know. I think this is sort of for both pathologists and the clinicians for reasons I'm going to just discuss maybe next few slides. And we did genetic studies. We do it for all the new cases. It did a first karyotype. It showed some abnormalities. Showed a clone with deletion 2 and some extra lesions with additional on chromosome 7. These were not really diagnostic. I think they are non-specific. Next. And FISH, we do also we have a ALL panel FISH, which didn't pick up any abnormality, and it was not MLL positive. BCR-ABL was negative. So, so we're dealing with something which is based on a flow diagnosis, and that we call ETP TALL. And the definition of that has been already basically delineated by a group back in 2009, and it became more and more clear that this is an entity which can be recognized by flow. It has its importance from the therapeutic point of view. We're going to talk about it in a bit. So how we describe it? It is anything. Sorry, Faraz, can you go back? Absence of CD1A and CD8 expression is the key, and then lack or dim expression of CD5. I think I didn't point it out because I was looking for this in one of the slides. This is another important feature of this, rather very important feature, and the presence of any myeloid marker or a stem cell marker, which in this case we have 11 we have CD13, CD33, 117, and then stem cell marker CD34 and HLA-DR. Actually, just yesterday, my colleague Tariq showed me a case of another ETP TALL with CD11B expression. It was exactly the same we had seen just in the slides before. Next slide. And just to revise for you, we have, based on CD1A and surface CD3 expression, 3 types of TALLs. One is early, the thymic, and the mature. This is not necessary for therapeutic purposes, but the one I have highlighted here in red, the ETP has therapeutic implications, and especially in adults. So this needs to be recognized, and it can be recognized by awareness and by a pathologist or a hematopathologist who knows how to tease out the differences between a biphenotypic, a clear TALL, early TALL, as well as ETP ALL. So next slide. And our own, very own Haitham Khogir did a very nice study some years ago. And actually just 2 years ago, it was published in BGH. This is 2021, so it seems like far away. And actually he showed really nicely the different markers, and actually has a scoring system. I would highly recommend going over this paper. And these stars or the asterisks there are indicative of the statistical significance, and one of them very highlighted in that paper was CD33. CD33 actually is highly expressed, and they did some in vitro studies which show that CD33 expression can be targeted by Myelotarg, and so they were really presenting that paper both to show the differences between the ETP and non-ETP, as well as to show that there is a possibility of using targeted therapy of these poor outcome TALLs. Next slide. And definitely our honored speaker for today, Dr. Jain, presented this paper, or published this paper in Blood in 2016. Probably one of the largest studies on this subject, where they took around 120 cases, and a lot of them were ETP, I think 19. Yeah, and they showed some very nice studies, the differences, and with the especially in the outcome. As you go to the next slide, which next slide, which definitely highlights that there was a poor survival in the patients with ETP compared with non-ETP, although the event-free survival wasn't really that much significant statistically, probably because of a number, and Dr. Jain can comment on that, I'm sure. Next. And that was a study in adults and adolescents, which is really important, to a point I want to highlight here, because it seems that in children, this statistical difference between the two groups, that ETP and non-ETP, does not bear out. And that was shown by Brentwood and his group, years ago and was published as abstract. I don't know if this paper has been published or not, but I attended this personally, and this was really eye-opening, because at that time everybody thought ETP in children was similarly bad as in adults, but it seems that with maybe DEXA and aggressive chemotherapy at early age, the difference kind of melts away. So it didn't seem that there was any difference in outcome there. So back to our management of the patient. This patient, alhamdulillah, was managed as per the protocol of ETP, because we picked this up on the right time after his diagnosis of TALL. We didn't stop there. We did the bone marrow, did the flow, and figured this out. And he did get, I think he was 15 maybe at the time, and I think he was seen by the pediatric. I'm not sure. Yeah, I think it was initially came to the pediatrics, and they did transplant this patient after going into CR. So that's the good news. And patient is currently still alive and long-term follow-up at KSH. Next slide. So so these are the key takeaway points from this case. I hope everybody understands it's important to correctly identify the poor outcome subtypes of TALL, because of therapeutic approaches are different from TALL. You know, a non-ETP would just need, you know, chemo and may respond very well. And it's a good response rate with chemo, aggressive chemotherapy, whereas ETP will not. It will come back with MRD, and you will have to transplant it sooner or later. And also highlighted in this case that a standard 8 to 10 color flow is really adequate and appropriate in classifying these cases. And it is an entity which is provisional entity in the WHO classification, but the way it's been described and the way it's been recognized and it's been established, I don't think any doubt that it's a separate entity in the future classification system. Lastly, as I mentioned, I want to highlight it again, ATP in adults is seen more and more common, but it's not, and it's seen actually, as in our case, as an adolescent, that it does present with neural presentation. So don't ignore requirement of flow, even if it's a neural presentation. Okay, so we go to the next one. I think we'll ask Dr. Jain at the end to comment, because he's the expert in this field, especially from therapeutic point of view. So case number 2. Are you appetite for another case? I can stop here. I don't mind.
I think we'll stop here for Q&A.
Absolutely, yeah, sure.
If we have time, we can go back for the second case.
Okay, absolutely. Thank you.
Thank you, Dr. Bakhshi. Excellent presentation and interesting, challenging case. So we'll move now to the last part of the webinar, which is the questions. We have received several questions. So I'll start with Dr. Jain. Is there a difference on the prevalence of Philadelphia-like based on the ethnicity?
Yeah, so yeah, there's certainly a difference. So I showed some data. So Philadelphia-like really appears to be more common. It is more common in patients of Hispanic ethnicity. So for example, because we are in US and in the south of US, so we have a lot of patients coming from Latin America, Mexico, you know, who are of Hispanic ethnicity. So that's why the number of patients we see, 1/3 of the patients at PH-like ALL, because a lot of patients who come to see us are Hispanic ethnicity. But if you go to some other European data, where there are not many patients with Hispanic ethnicity, the incidence of PH-like ALL may be like 10 or 15%. So there is a strong association, and I think, you know, it remains to be seen. You know, I think we don't know for different subgroup, other ethnicity for that matter. Like there is no large series from other groups to figure out what is the incidence of this, you know, in other groups of patients. But for sure, Hispanic ethnicity, the incidence appears to be the highest.
Hey, another question regarding the higher MRD rate in Philadelphia-like ALL. Do you expect a similar response using Plenatomab for Philadelphia-like versus non-Philadelphia-like?
Yeah, so I think many studies, including our study, have shown that if you use chemotherapy, especially the CRF2 patients, because they have activation of JAK-STAT pathway, and I presume that's the reason these patients are very proliferate. They are resistant to chemotherapy. So that is well established that if you are using standard chemotherapy, these patients will very likely remain MRD positive after induction. The data with Plenatomab, there's some recent data I showed in my slides towards the end, which showed that maybe Plenatomab can overcome the negative prognostication of Philadelphia Light. But the number of patients treated were like 16 patients and 12 responded. So I think we need to have some larger data set to kind of confirm that finding. And the same is still, we don't know with inotuzumab and CAR-T. But one could argue that these therapies may work for these patients given, these therapies tend to work many times irrespective of the genetic constitution of the patient.
Okay. So I will move to Dr. Horeji. So there are several questions about COVID and ALL. So the first one I will take is, what are the risk factors for poor outcome of COVID infection in ALL? Do we know any?
I think from the CCC consortium, the data, thousands of people with malignant hematological diseases, they tend to have a higher complication rates. And I don't know exactly about ALL, but they tend to have a higher mortality rate, especially if they're on active therapy, and especially if they're receiving B-cell receptor antagonists such as monoclonal antibodies like rituximab or other that can lead to hypogammaglobulinemia.
Okay. So there is a question regarding the use of steroid in COVID and ALL. What are your thoughts, Dr. Horeji?
I think it's okay to use. I think it can have two targets: the ALL and as well as the data from UK that dexamethasone has shown to be beneficial in patients with COVID pneumonia.
Okay, Dr. Bakhshi, so we have a question regarding the shift of the clone from B to T, or sometimes to the myeloid. When a patient has such a disease, are these or those different diseases, or actually undiagnosed mixed phenotype?
Sorry, I didn't understand about a shift of clone part, but
so the question here is that a patient got diagnosed with for example, BALL, then he relapsed with a different clone.
Yeah, you're relapsed with the myeloid, most likely you're talking about. Yeah, those can be the ones which are truly biphenyl, and we call it Aml now to begin with, but were missed because of the sensitivity of that assay, or what they were utilizing was not good, or there was a subjectivity of the Aml, which is described as a mixed phenotype acute leukemia, is a diagnosis which is based on actually MPO. Essentially, if you don't read MPO properly, you are gonna mistake it. Clearly, it's one of the, I would say, a big pitfalls in flow cytometry, and we have to. I'm seeing it quite often here, especially in Saudi Arabia. A lot of the referral cases we get called MPAL. What happens is they don't use the internal control properly. They don't use the isotype controls. So which results in, and because a lot of times there's autofluorescence. I think I showed you one of the slides there that autofluorescence can be mistaken as being positive. So you need to first realize where your positive starts. So I think it's a technical thing. I'm not gonna bore you with a lot of details, but my point is it does happen most likely because of mistaken identity rather than because of true shift of clone, which I don't think happens from one. There is promiscuity about the markers. Some of the markers become expressed later on. B cell may have one or two markers, but it's not a shift of a B cell to a T cell or a B cell to a myeloid. It doesn't happen. I think that's kind of either rare, very rare, or it's probably, scientifically, it just doesn't make sense. I would say it's basically a technical thing, rather than a true or genuine shift of the clone. I think, is that the question?
Thank you, Dr. Bakshi. Any comments about this question from the panelists?
So one thing I may add is that sometimes we do see, like for patients with MLL rearrangement, 11q23, it has been described that patients who are diagnosed with BLL with MLL rearrangement, you give them Plenatomab, and then they kind of relapse with an AML-like clone. That has also been described with the CAR T-cell therapy. So, I think these are the patients who obviously MLL, mixed lineage leukemia, so they probably have these clones present up front, and then you give a CD19-directed therapy, you clear out that clone, and what emerges is like a myeloid clone. And so I think that's something, sometimes therapy can induce this lineage switch, which, as I said, has been now described with several case reports with MLL patients.
Thank you. Another question to you, Dr. Bakshi, from Dr. Mohammadi. What's the prognostic utility of day 14 bone marrow?
Actually, nothing. I don't. I've worked in many centers, and some places actually ditch it. They don't do it at all. We can hear it from the experts. I don't see any good reason. It has been also been checked out by the COG group that if you do, day 8, I think they were talking about very early assessment for the MRD, but said it's not useful. So they are no longer, I don't think, recommending it. But day 14, I don't see much. It's basically a clinical decision. I'd see, as I said, in many centers they don't do day 14, but I think if you feel comfortable to see whether there is a response to therapy, maybe you want to check it early on. But day 28 is where the real issue about the response, the MRD, and the change of the management happens. But I would say if you say, for example, have a day 14 marrow, we do it here in our center, and you see blasts, you're not going to change your management, are you? I doubt it. At that point, you will wait till you get more time to the patient. And as I said, it's a clinical decision, and we are basically respecting if you feel comfortable with day 14. But I don't know, clinically, is it useful? We can ask again the experts. It's not really something, I can say it's written on stone that you don't have to do it or you have to do it. It's something very flexible. But to me, I don't see much advantage, to be honest.
Let's hear from our other panelists about their practice regarding day 14. Dr. Haraji?
When you're using a hyper-CVAD protocol, we usually tend to do it at, we don't do day 14, we tend to have 3 to 4 weeks assessment. And then at that time, that made the prognostication for our patients, as well as at 3 months time point or post-cycle 3. However, in our center, we're using the Pediatric Protocol, which is by the UK ALL, up to the age of 24. And in this protocol, we tend to do the day 8 bone marrow to then stratify the patients whether they will go to high risk arm or they will continue on the intermediate risk arm.
Dr. Jain?
Our practice is also because we use hyper-CVAD practically for most of our patients in some fashion or the other. We do day 14 bone marrow for patients, and then, but as Dr. Bakshi said, I think we don't make treatment decisions per se based on that. Like, we're not changing therapy on day 14. But overall, if you look at historical studies, I think day 14 has been shown to be prognostic. Now, at the end of the day, if someone is day 14 MRD positive or has disease, and by day 28 they're MRD negative, am I going to take this patient to transplant saying that their day 14 was positive, maybe they're high risk? So probably not. I think at the end of the day, treatment decisions are based on day 28 marrow and forward, but we do tend to do day 14 bone marrow. I don't know if recently if we have looked specifically at day 14 bone marrow prognostication for our patients here, but that's something maybe to look at again.
Thank you all. Question to Dr. Jain regarding CAR T-cell and ALL. Are we expecting a change in the upper age limit, which is 25 for CAR T-cell and ALL soon?
Yeah, so I mean, right now, obviously, that upper age limit comes from the trial of Kymriah, the Novartis RT, which was studied for pediatric and up until the age of 25 years. So the adult ALL, the CAR-T has kind of lagged behind a bit as compared to what I've seen with non-Hodgkin's lymphoma. So, but there are now ongoing trials by big pharmaceutical companies, including Kite and Juno Therapeutics, to develop CAR-T for adult ALL. And there are also a lot of allogenic CAR-T for adult ALL, which are coming along, which I am personally involved with quite a bit now. So I think the field of adult ALL is moving forward. I think when we'll have the adult ALL CAR-T approved, maybe the Kite product, maybe the Juno product, maybe the Juno or Kite, maybe the first one to kind of maybe make that headway. But I'm not sure aware of the timelines. But at the same time, I think a lot of trials are being done now for adult ALL, because the outcomes remain suboptimal even with Plenatomab and Anituzumab. These are not curative therapy in general.
Thank you. Question, Dr. Hareji. Management of isolated extramedullary relapses or disease ALL versus medullary. Do you make any differences in the management?
Yeah, I think extramedullary disease, we sometimes tend to see it between now and then, but we usually we treat them with chemotherapy along with the radiation to the involved sites, sometimes either the testicular relapse or CNS relapse. So we tend to have more radiotherapy in the protocol along with intrathecal chemotherapy as well. So, and we take them for transplant with preferably a TBI-based conditioning regimen for transplant.
Thank you. So there is a question. So one is Dr. Musani is asking regarding the spontaneous cure of ALL. He has seen it in few patients. I don't know what are the thoughts of our panelists without a treatment.
So, we I don't think recently, but when I was a leukemia fellow here, at MD Anderson, I published with one of my attendings here at that time a series. It was, I think, mostly AML. It was spontaneous remission of AML. We had 4 patients in the preceding, I think, 20 years or so at MD Anderson. Along with, I reviewed the literature which was published up until that time. That was, I think, 2007. I'm talking about. And what the unifying theme was that most of these patients had some kind of an infection, and they came with low counts or maybe high counts. They had some kind of an infection at that time. You delayed their induction because you're worried about pneumonia or whatever they were having, and somehow maybe that cytokine storm led to this transient remission. But most of these patients then relapsed within 2 or 3 months. Not relapsed, I guess, or kind of came back. There were some patients who had some long-standing remissions. So these are kind of, I guess, extremely rare scenarios, though has been described. And again, most of this has in the context of some active infection.
So I can tell you from my experience, I had seen some patient who went into remission. The claim is that they did not receive anything. Then when they relapsed, they admit that they received herbal treatment, alternative medicine treatment. And then a few times we took those medicine and did analysis, and we realized actually there were steroid on the herbal medicine added, sometimes 6-MB. Definitely spontaneous resolution of the disease of whether it's a lymphoma or ALL has been reported. It is very rare, but it has been reported. Question to Dr. Bakhshi regarding the flow cytometry for CSF in ALL. Do you do it routinely?
I'm sure it's one of my clinical colleagues, because they are very concerned about. Yeah, we don't know it every single case. We basically triage. When we see there is a typical cells, anywhere there is suspicion, anytime there is a suspicion whether the patient has leukemia or not, we do flow. But the only problem is the cell count. The least we can do is, we have to, we still do a chamber counting for the CSF, and we need to have at least 1 to 2 cells. Okay, the normal CSF cell count is up to 5, right? 0 to 5. So if it is less than 1, it means there are hardly any cells. There will be a problem to get enough numbers for flow to do accurate counting of blasts, or for example, lymphoma. The other issue is the timing. CSF is not something, you would just, keep it for, day or so. I would say within 12 hours, preferably within 6 hours, it has to be done. So I recommend, if somebody from our center is interested or is keen to have a flow done on a specimen, on a CSF they're concerned about, it's good practice not to send it for chemistry, all sorts of hematology counting, and just send it directly to flow. That way it will save the time from processing, reaching to the lab, and us being more alert to it. So we'll do the processing in the flow directly and run it depending obviously on the triaging. If the triage and it shows atypical, as I mentioned. And this question was posed to one of the visiting professors last year or a year before. It's been a year, yeah, already. Dr. Wendy Stock, and she actually answered the same way. She said they don't do flow in every case. It gets triaged, and there is a reason to flow it according to the type of cell or of the abnormality. Then they would flow it. It's just simply as simple as that. Yeah.
Thank you, Dr. Bakshi. I think at this time we reached the end of the webinar. On behalf of the attendees as well as the society, I would like to thank our renowned speakers, Dr. Bakshi, Dr. Nitin Jain, as well as Dr. Hareji. Thank you for the attendees. I would like to remind attendees that CMA will be added automatically for those who attended 50%. There is an evaluation survey, kindly fill it. Thank you all and stay safe.
Thank you. Thank you for us.
Thank you,
everyone. All right.
Thank you. Good night. Bye.